Okay. So far all we've covered is the DSM criteria. DSM criterion, we're good on that. I'll get back over that in a minute. A little bit of statistics about OCD. There is a 1.2% overall prevalence in the population. So, thinking about that compared to other disorders, like when we talk about depression in a couple of weeks, that's about a 20% prevalence. So pretty rare condition. I mean, not rare, but 1.2%, right? There is a gender effect, tends to affect females much more than males, so about 1.8% in females and only 0.5% in males. There's a lifetime prevalence of 2.3%. The average age of onset is, as I mentioned, early adulthood, 19 and a half years of age. Although there's a subset of OCD that can have onset around 10 years of age. We'll talk about the pediatric form of that. 90% of people who are diagnosed with OCD have a comorbid diagnosis. Most of the time, that is an anxiety diagnosis, including panic disorder or phobia or PTSD, 75% of the time. Mood disorders are next, including major depressive disorder, bipolar disorder, and then ADHD and substance abuse disorders are also in that bag. All right, so as I mentioned, there's sort of two differential subsets of this, and so here we see, the age of onset, and so typically we see this big spike in the 20s that's associated with the onset of obsessive compulsive disorder. People usually don't acquire obsessive compulsive disorder in their 40s, 50s, like outside of that 20 to 30 year range. So in early adulthood. However, there is this population of children that around 6 to 9 years of age sometimes start to exhibit these symptoms and get a diagnosis. So there's sort of a bimodal distribution of a pediatric form and an adult form. We think those are fundamentally different. They have sort of like what we talked about with like autism, you might have different causes but the same diagnosis. Similar thing. We think that the pediatric form is different cause than the adult form. So PANDAS is an acronym that stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infections. So essentially the strep bacteria can cause changes in the basal ganglia that produce obsessive compulsive disorder symptoms. And these symptoms usually happen sort of out of the blue, and because it's in a child population, it's often harder to understand, right? So we don't, children start acting unusual, and we don't really, they can't vocalize what's happening to them or how they're feeling necessarily, right? So the strep bacteria is actually one of the oldest bacteria, we think, that exists, and they are very good, this bacteria is very good at using that molecular mimicry that we talked about with multiple sclerosis and the EBS virus, right? So this is a bacteria, not a virus, but it does the same thing, and it can hide from the immune system in your body by mimicking the antigen molecules that are normally in our body, right? Eventually, the immune system will create antibodies for strep, but there's this cross-reactivity with basal ganglia neurons. And so what we think happens in this PANDAS is that the immune system actually attacks and destroys neurons in the basal ganglia, and that's what's causing OCD in these children. Okay, risk factors. There's definitely genetic linkages, but it is complex and involves multiple genes, and it is related to a susceptibility, not a predictability, right? So while there is a genetic influence, it's more on the susceptibility side. There's definitely changes in the basal ganglia and the brain structure that also underlies this. These are not typically easy to detect. They're not volumetric, so it's not like we can do a brain scan and see a smaller part of the basal ganglia, that sort of thing. But there are changes in the connectivity and in the release, or in the expression of dopamine receptors in the basal ganglia. And there's also a relationship between trauma, particularly in childhood or early adolescence, that's associated with the onset of OCD. And we'll see that in one of our case studies that we'll watch on Monday. So all of these three things sort of combined together create sort of the perfect storm where obsessive compulsive disorder comes out of that. So we have three things that can cause susceptibility: genes, brain structure, and experience trauma. Okay, we've seen this a couple of times. Just going to show it to you again, is that we have this loop between the frontal lobe, particularly the dorsolateral prefrontal cortex, going through the basal ganglia, being regulated. Remember, the basal ganglia is kind of like a wet blanket. It kind of keeps everything calm and even and steady, keeps everything in control. And then back to the ventromedial prefrontal cortex, which is involved with sort of inhibiting inappropriate behaviors, right? So this whole circuit functions, nicely, normally, and it has, again, three different basic functions. Excuse me. One that we talked about with movement, right, with Parkinson's and Huntington's, all of those things. But there's also this role in both affective emotion regulation and in sort of cognitive regulation as well. All right. So these are the structures, and remember, all of these structures, the caudate and the putamen, are often referred to as the striatum. So if you see striatum, think, okay, that's the input coming into the basal ganglia. Basal ganglia is regulating it, coming back through the thalamus, back to the cortex. All right, I'm going to talk a little bit about memory, learning and memory, because at its core, we think, obsessive compulsive disorder is it utilizes those subconscious learning mechanisms that we've talked about. So non-declarative memory, subconscious learning, skills and habits are regulated through the amygdala for reward, right? So when we talk about operant conditioning, we're talking about reward and punishment. So the amygdala involved in that, and the cerebellum and hippocampus, but particularly the cerebellum, it's much more, it's not the hippocampus tends to be that declarative, factual type of learning. This is more of a habitual skill behavior learning. And so skills and habits through the striatum, the motor cortex, and the cerebellum, and all those things are sort of wrapped up together. We're good? Okay. Associative learning, so forming these associations often happens through, as I mentioned, the hippocampus, but particularly the cerebellum. And those things can be stored down here in the temporal lobe, where we also have the amygdala down here for the reward and punishment areas. All right, so as we mentioned at the start, obsessions are intrusive, reoccurring thoughts that cause distress. And the top, if we look at what are the percentage of patients that show it, the top obsession has to do with dirt, being dirty, not being clean, germs, and sort of the environmental toxins, right? That's 40% of obsessive compulsive patients have that type of intrusive thought. The next intrusive thought is sort of a general anxiety that something bad is about to happen and we have no control over it, right? That someone's about to, like a loved one's about to die, is a common one, or someone's about to kill me is another common one, or just this overwhelming, sort of paralyzing feeling of anxiety. These are often then get linked to the compulsions, right? And so if your obsessive thought is that you're dirty and you have germs and you're going to get sick, what's your natural response to that?
Wash your hands.
Wash your hands, right? Except when you wash your hands, that feeling doesn't go away. So normally you and I, we're like, ooh, I just touched something that was not good. When I go wash my hands, you wash your hands and it's all gone, all good. That obsessive thought doesn't go away. And so what do? What does that person do? They wash their hands again, and they wash their hands again, and they wash their hands for 20 minutes, right? And all of a sudden, this is becoming linked to that. Repeated rituals often seem sort of nonsensical, but what we think happens is, someone has this feeling of anxiety or things are out of order, and so they move and rearrange everything in their bathroom so that the shortest containers are on the left and they get taller to the right. And once they do that, the obsessive thought goes away, and all of a sudden there's this classical conditioning and operant conditioning effect that happens where they learn to associate the removal of the negative punishment as a reward for having done this behavior. Or they are having an anxiety attack and they walk in the room and turn the lights on, and when they turn the lights on, it goes away. And all of a sudden they don't even think, it's not consciously they're yeah, turn the lights on, and it went away. But the fact that they flip the light switch becomes associated with the removal of that punishment. And so that then becomes linked. And the next time they have that anxiety, they go over and turn the lights on and it doesn't go away. So what do? They turn them off and turn them on again. They turn them off and they turn them on again. And eventually, 20 times later, the anxiety goes away and that gets further reinforced in the brain, right? So this is how sort of very kind of odd behaviors can get associated with, as a compulsive behavior with these obsessions.
Where does the counting come in?
The counting, right. Again, we think that somebody is maybe they're walking to the door and they take 5 steps to the door and the anxiety goes away. And they don't even realize this, right? And then when the next time they have anxiety, they're like, okay, if I take 5 steps, maybe it'll go away, that sort of thing, like that. Does that make sense? So it's difficult to explain, and this is a theory, we don't know this is what's happening, right? But this is our best guess at why these sort of kind of bizarre behaviors get associated with the removal of the punishment of the anxiety. All right. Touching, counting, ordering, and arranging, these are all also very common sorts of things. All right, so let's talk about what's happening. So we have this loop, right? The frontal lobe is where the anxiety, the thought originates, right? And that goes through the basal ganglia, and in a non-susceptible brain, right, that's functioning in a healthy way, the basal ganglia shuts down that thought, right? Or we perform, I feel like I touched something dirty, I wash my hands, I do a motor response, and that resolves the anxiety, right? But when the regulator's not working, when we have a lack of control, that input into the basal ganglia doesn't get shut down, and it loops back around into the frontal lobe and sort of reinforces the anxiety. And so we get this loop that's happening, this anxiety loop of lack of control through the basal ganglia. And so what does the person start doing? They start doing things, motor responses, to try and alleviate that anxiety, right? So motor responses are also going through what? The basal ganglia. So it's here that the anxiety and the motor response are happening at the same time. And when two things happen repeatedly at the same time, that's when we get classical conditioning, right? And so now we're learning subconsciously that the motor response belongs with the anxiety. We good on that? Classical conditioning, these things become associated strongly with each other. And then, not because we're doing the motor response, but the anxiety just stops, right? It just goes away on its own, naturally. But because we're doing this motor response, when it goes away, there's an operant conditioning effect that happens, right? That reinforces doing that abnormal behavior, right? So there are two things that happen. Initially, we're pairing the anxiety with the behavior, and that can actually lead to where the anxiety then directly evokes the behavior, and that's why they feel compelled to do it. They feel like they have to do that thing. It's the only way the anxiety will go away, right? And when it does go away, the brain's like, see, I told you, you had to wash your hands for 20 minutes, and now it went away. And that further reinforces it to operant conditioning. All right, we've already talked about the neurochemistry, so this is kind of a review of the neurochemistry of the basal ganglia, but we have a role for both serotonin in this regulation. We haven't really talked about serotonin too much. We don't see any measurable differences in like serotonin metabolites, but because SSRIs, because medications, serotonin medications can sometimes effectively treat this disorder, that's been sort of associated and looped into OCD. Dopamine, we also know, is a major sort of regulator, as we saw with Parkinson's disease. And there's some evidence of decreased dopamine receptors in the basal ganglia. So when we talk about neuroanatomical susceptibility, if you happen to have a basal ganglia that has 90% of the D2 receptors that most people have, then that makes it more susceptible to this cycle happening in the basal ganglia and not working effectively, right? We also have glutamate coming in. That's the obsessive thought. The anxiety is causing excess glutamate to be released into the basal ganglia. And then, as we saw, most of the connections within the basal ganglia are GABAergic. They are inhibitory from one structure to the next structure to provide that regulation. And lastly, there are two neurotransmitters, vasopressin and oxytocin, that appear higher often in OCD populations, and those play some kind of complex neuromodulatory role that we don't fully understand. So again, a correlative thing that we can look at your blood plasma and see some elevated levels of vasopressin and oxytocin, but we don't really know what that means. But we know they play some kind of modulatory role. So why do we care about all this? Because this makes it really hard to create a drug treatment, because there are multiple neurotransmitter systems involved, and targeting glutamate and GABA is really difficult because of the side effects, because glutamate and GABA are so ubiquitous throughout the rest of the brain and other systems. So most of the, we'll talk about an experimental glutamate treatment, but most of the drug treatment is targeting either serotonin or dopamine. But it's not as effective because it's not a simple one neurotransmitter involved with this complex system. All right, so go to the mall, Mackenzie, go to the mall, right? You're gonna run in, you're only gonna be there for 5 minutes because you're just running into this one store, you gotta grab something, right? And as you're walking in the mall, you think, did I lock my car? What do?
I turn around and go see if I locked my car.
Okay, so you turn around and you go back and do what?
Try to open the door.
Try to open the door, right? Or you push your remote and hear it honk and you're like, oh, locked, okay. And then what do?
Go back into the mall.
Go take care of your business, right? Go about your day, right? Or does someone else have a different response to that? And that's a pretty common typical response. I mean, you could just say, maybe I didn't lock my door, it's okay. I'm only gonna be here 5 minutes, nothing's gonna happen to my car. I'll be right back. Just run in and do it, and that goes away, right?
I usually like hit the car button.
Yeah,
Like
car button. Right, and if you have to walk back a few feet so it'll reach, right?
And sometimes I'll do it like.
Okay. With someone who has OCD, they do that, and even though they know, again, they have good insight, they understand this is abnormal, even though they know that the car's locked, I heard it honk, right? That doesn't go, the anxiety doesn't go away, right? And so if they then say, okay, I know I locked it, I'm just gonna go in and do my business, that anxiety doesn't go away, and it builds and it builds and it builds, and they start extrapolating that to someone's breaking into my car, right? Someone's, my car's gonna be gone when I get back out there. Like this anxiety builds and builds, and so they keep going back and doing it, and so now they've hung their car 20 times, and eventually, again, that it provokes that compulsive behavior, and eventually, when the anxiety subsides, they associate the compulsive behavior with having alleviated the anxiety. Even though it really had nothing to do with the anxiety going away, it just subsided, right? But this behavior then becomes linked with this. Yes, Mackenzie?
Does this only happen with like stuff that you do like regularly? Like, because I feel like the memory aspect of it, like you don't remember if you did it because it's something you do all the time, so you can like remember another time you did it.
Yeah.
So does it happen with other stuff that you don't do often?
Sometimes, right? And as OCD sort of takes root, like the initial thing that was associated with that, so maybe we'll see I'll try and point this out on Monday when we see a case study. It helps to see the case studies because that helps you understand. But there's a young lady who has to have everything in order, has to have symmetry, and she also has, often there's some sort of religious connotation. So if your anxiety is something bad's going to happen to somebody, they often think, okay, God can prevent that, and so somehow I have to appease God. And so she would talk about like order, and then she has to like look up at the left because God's on the left, not on the right. She's like, I don't know why, it just is. And so sometimes very unusual behaviors that you wouldn't normally do get looped into this. And again, people usually have good insight. They're like, I know this is really weird, but if I do this, it prevents the anxiety or it stops the anxiety. All right, treatments. Behavioral and physiological. So we have first line treatments, and then we have treatment resistant options. So first line treatment, psychotherapy, number one, behavioral. We'll talk about CBT and ERP. So cognitive behavioral therapy that we already talked about with PTSD, exposure response prevention. Expose someone to trigger the anxiety, prevent them from doing the compulsive behavior. Teach them that they can control that those thoughts are inappropriate, they can relabel them, and that they can cognitively learn how to control them without doing the behavior. Right? Physiologically, SSRIs and one tricyclic, that's what TCA is, tricyclic, have been approved for the treatment of obsessive compulsive disorder and may have some effectiveness. We'll talk about that. There are some people that these things don't resolve their OCD, right? They've tried these things, and so then they become in a category we call treatment resistant. And in treatment resistant patients, we can take some more dramatic steps of controlling the basal ganglia like we saw with Parkinson's disease, where you can have this thing called deep transcranial magnetic stimulation. So this is essentially, so you know about ECT, which is electrical convulsive therapy, where they actually put electrodes and like shoot electricity, and that can shape circuits, and we'll talk about that in depression. That's not used here, but a similar thing that's less invasive, which is using magnetic waves to stimulate the brain, and it's called deep because we're doing this deep in the brain in the subcortical areas of the basic ganglia, right? This has become more and more common. In fact, right before class, I just Googled deep TMS Spartanburg, and there's 3 treatment centers in Greenville that offer this as treatment. So it's something that's becoming more and more readily available to the public. Yeah.
When people get like deep brain stimulation and deep like those, I know there's no like sensory on your brain. Do they feel anything? Like what does it feel like? Does it feel like anything?
Mm-hmm.
That's crazy.
Yeah. We can also have DBS that we talk about, where you implant an electrode into the basic ganglia. Surgery, neurosurgery, invasive, permanent, one of our research papers talks about some of the issues with this. Batteries die, they have to be replaced, you have to fine tune it. It's much more difficult to fine tune DBS for a cognitive disorder like OCD than a motor disorder where we can see, okay, the tremor's getting less, it's getting less, we can turn it up, okay, that's it, that's the right level, there's no more tremor, right? Much more difficult. That's why this non-invasive is sort of preferred. And then lastly, we can, just like with, we saw with Parkinson's, we can go in and lesion this connection and physically break that loop that is being activated. All right, so let's look at some of the drug treatments. So CMI is the tricyclic that I mentioned. This has been approved to treat this. DMI is a selective norepinephrine reuptake inhibitor. And what we see is that in placebo, no difference between these in terms of their symptoms. We put them on the 2 drugs, 2 different groups of people, and the people on the tricyclic, after 4 weeks of being on the drug, show improvement of their symptoms, right? Is this a neurochemical imbalance in the brain? When previously did we talk about a disorder being a neurochemical imbalance in the brain? Come on, you guys know this stuff. What disorder could you take a drug and in 20 minutes you restore the function of that? Huh? Yeah, so Parkinson's, we don't have enough dopamine. It's a neurochemical imbalance. You take a drug, as soon as the drug has effect, you restore that neurochemical imbalance and it goes away. This takes 4 weeks to have its effect. Is that a neurochemical imbalance? No. There's something about turning up the neurotransmitters involved by this drug that over time changes circuits in the brain, and over time, over weeks, those symptoms then improve. So the drug effect is on the circuitry in the brain. Over time, it's not a neurochemical imbalance. Now, here at 8 weeks, we do a mean experimental thing. We're going to switch the drugs in the 2 groups. And so now the group that didn't have the tricyclic gets it, and the group that had the tricyclic now gets the norepinephrine reuptake inhibitor, and they start to get worse, and the group that wasn't doing great gets a lot better. So this sort of shows that it actually is the actions of the tricyclic that are improving the symptoms. But again, 4 to 5 weeks to get that improvement, right? So it's acting on circuits in the brain. Okay. So what does the tricyclic do? The tricyclic blocks both serotonin and norepinephrine reuptake, but it has lots of side effects, and there's an overdose risk that can be associated with that drug, so it's not completely safe. SSRIs are more selective to serotonin, right? That's the SS, selective serotonin reuptake inhibitors. And those are typically safer and more tolerated. And here we see, if you look right here, this is the basal ganglia right here showing high levels of activity. After treatment with SSRIs, we're seeing lower levels of treatment in this neurospec scan in the basal ganglia. But again, it's not a chemical imbalance. It takes weeks to see this effect. So the presence of these drugs is changing the ability of the basal ganglia to do its job, improving the ability of the basal ganglia to do its job, right? Sometimes it can take months, up to 6 months, to have its maximal effect. All right. We know serotonin plays a modulatory role in the brain. So again, shaping the excitability of other circuits is how this is happening. It has a 50 to 70% success rate, although some studies have suggested that up to 50% of that might be a placebo effect. So you can generate a placebo effect with telling someone they're on an SSRI and they're not, and symptoms improve, right? But if you take away the medication, there's a very high relapse rate. People become dependent on that medication in order to have the alleviation of the symptoms. Occasionally, the dopamine 2 antagonist drugs have been used to also regulate this, but they have significant side effects. So sort of SSRIs are the common drug treatment just because of the lack of side effects that are seen. So doctors are much more willing to sort of prescribe them. Okay. Again, here we see hyperactivity in the basal ganglia. After drug treatment, less activity. But here we see hyperactivity in another person's basal ganglia after successful behavioral treatment, a reduction in that activity. So successful CBT people can learn to self-regulate that activity and down-regulate it naturally without the effect of drugs. Okay. And so here we see, this is research here that's showing essentially this is pre-treatment at 0, and then we see a decrease in the activity after the treatment in the basal ganglia. All right. As I mentioned, there's a new drug, Riluzole, I guess is how you would say that, which is a type of metabotropic glutamate receptor 2 agonist, and that receptor is a feedback mechanism. It's an autoreceptor, and so if we are having too much dopamine coming in from the frontal lobes into the basal ganglia, this drug essentially acts to tell those neurons that there's this high level of glutamate and that they don't need to release as much, and so it effectively causes a reduction in glutamate release. One of the things about this is we're trying to get drugs that act selectively only on glutamate in the basal ganglia as opposed to glutamate everywhere else that it exists throughout the brain. And so that's one of the tricks of this, one of the issues with this. But again, we do see over time this improvement in this regulation. Again, not a chemical imbalance. It's not just there's too much glutamate coming in, because it takes weeks and months in order to see these effects. Okay, so talking about going from first-line treatment to treatment-resistant, this chart sort of outlines the timeline. And so, you know, we have someone with moderate, mild OCD. We're going to start with CBT or a SSRI. Do they improve? Great. Then we taper and go to booster sessions. If not, then we add in the other thing we weren't doing. So if we have CBT, maybe they need drugs to get better with the CBT. Again, improvement in 12 weeks, so now we're at 24 weeks, right? Because it takes a long time for these effects to take place. So essentially, by the time you get down here, so okay, no effect there, no effect here, we get down to here, this is where you're now labeled as treatment resistant, and we can start talking about things like DBS or ablative neurosurgery or transcranial magnetic stimulation. But here, we're at 8 to 12 months of ineffective treatment, first-line treatment, to get labeled as treatment resistant. Right? Okay. Cognitive behavioral therapy. Just like we talked about with PTSD, these are weekly sessions with a counselor where patient clients are learning to explore their feelings and what triggers their anxiety, and they're learning to label that as a disorder in their brain and it's not natural, and they're learning how to control that. And they're given homework assignments. You have to practice this. CBT doesn't work without patient buy-in. You have to have the patient willing to participate and willing to apply the cognitive tools that you're giving them, right? And so these are the same components, the same 4 components that we talked about with PTSD: relabeling the anxious thoughts, reattributing them due to I have a disorder, refocusing and revaluing in terms of the cognitive toolkit to learn how to harness those. And then the 5th thing that we add in with, particularly with OCD, is exposure response prevention, triggering the anxiety and then utilizing these to control the anxiety and preventing the compulsive behavior from happening. And again, we'll see this in our case studies on Monday. Okay, so just like we talked about with PTSD, in PTSD you have this big traumatic event and it's like single trial learning, you end up here and you have this thing associated. This is more of a gradual acquisition, the classical conditioning. So we can use that, because it was classically conditioned, we can use the principles of extinction, exposure response prevention, right, to break that learned association. But again, sometimes we can have spontaneous recovery, and so booster sessions going back once a month over a period of a year, 2 years, or maybe even longer can help prevent that, help remind people, hey, this is something that you are able to cognitively control, but only if you practice it. If you don't practice it, it can pop right back up, right? Okay, when you've had failure of 2 SSRI treatments and CBT, that's when you qualify for something like deep brain stimulation. And here, again, not immediately effective. We are using now energy to shape those circuits instead of drugs, right? And it takes weeks to see the maximum benefit of that, right? We have some people that don't respond to this, right? So we have responders and we have non-responders also. So it doesn't even work for everybody, even in this treatment-resistant area. Okay, I think I covered all that, right? And so obviously, I mean, you've already not responded to significant treatments here, so some people this doesn't even work for in this phase. This is data looking at deep brain stimulation instead of transcranial magnetic stimulation. Again, it improves over time. So unlike Parkinson's, where you turn it on and the symptoms immediately go away, this has to be chronic stimulation, and that chronic stimulation is changing the circuits in the basic ganglia so that they're less abnormal circuitry and more normal circuitry that can control the loop effectively. Again, we have some people that are non-responsive, some people partially responsive, some people that are, that's the sham. So even with a sham, right, we have a placebo effect that can happen. here, right? That's placebo effect. Here we see much bigger response when we're actually actively stimulating it, but we still have people that get partial response or no response to that. All right. This again is just showing the implantation of these electrodes bilaterally into the targets here of the striatum. And again, showing that it takes time. These are months, right? So over the period of a year, it improves and it can stay sort of improved over long periods of time. There are several different surgeries, again, that can sever this connection between the basal ganglia and the frontal lobe. And 4 different procedures. They have varying rates of success. Typically, they tend to be fairly successful. And here you see this lesion bilaterally here that has severed the connection between the frontal lobes and the basal ganglia to break that loop. Very much last resort when a lot of other things haven't worked. Sort of, I mean, this is a permanent thing, it's not reversible, it could have potential side effects.
What else could that affect?
I mean, it could affect a lot of things. It could change your personality. I mean, it could affect your ability to show emotion, like all the things the basal ganglia and the frontal lobe are involved with. Okay, so treatment. So here's our broken brain. I want to say brain. Our OCD brain that's abnormal. Not abnormal, but I don't know the politically correct words to say anymore. But this is what it looks like when it's not working well and we have OCD, right? We can put drugs in that are going to act in the basal ganglia to prevent that lack of control, right? We can put TBS or DBS, TMS is typically affecting the frontal lobes, DBS is targeting the basal ganglia. We can have surgery to sever that connection between the two, right? Or we can have cognitive behavioral therapy and exposure response where we break the learned association between these two, right? We learn how to control the anxiety loop, right? And so this is why this is like the best therapy, is because it effectively does all 3 things that these can do without a physical intervention in the brain. Not a physical intervention in the brain. All right. Research papers, sort of research case study-ish papers on Friday. Please read them so that I can ask you questions and you can answer them without looking it up in the paper. And then on Monday we'll have our case studies, which are video case studies for this. It's much easier to see this in action than it is to sort of read about it. Be preparing, doing the review points. If you have questions for the exam, just reach out to me by email or stop by my office.
Thank you.
Yes?